Welcome to Diabetes Day by Day, the American Diabetes Association's official podcast. For this month's episode, we're going to talk about a critically important topic, kidney health. Specifically, we're going to discuss preventing and slowing the progression of diabetic kidney disease. This episode is sponsored by DaVita IKC. I'm Dr. Neil Skolnik, Professor of Family and Community Medicine in the Sidney Kimmel Medical College of Thomas Jefferson University, and joining me is my co-host.
I'm Dr. Sarah Wettergreen, an assistant professor at the University of Colorado Skaggs School of Pharmacy and an ambulatory care clinical pharmacist.
To help us learn more about this important topic, we have a true expert in the field, Dr. Michael O'Shea, who spent 20 years practicing nephrology in New Hampshire at Dartmouth Hitchcock Health's Cheshire Medical Center, and who is currently Vice President, Clinical Leadership for DaVita. Welcome, Michael.
Thank you, Neil. It's a great pleasure to be here and an honor. Thank you for inviting me.
Oh, it's so great to have you here. You know, to start out, can you tell us a little bit about what DaVita is, what its mission is, as well as your interest in this topic and what you do there?
Great. Thank you. To answer your first question, DaVita is traditionally viewed as a dialysis company, but I think that you should know that it's really DaVita Healthcare, which is a kidney care company with an interest in looking after the kidney health of patients across the entire spectrum of kidney disease. So our focus certainly now for the past 10 years and going into the future is going to be giving patients the best kidney health possible according to what they want and their needs at the time, meaning in most cases, preferably that we slow or even stop the progression of chronic kidney disease, that we see more patients transplanted, and yes, if necessary, if patients need dialysis, that we are there for them in that setting as well. Here at DaVita, I, as you mentioned, am one of the VPs for clinical leadership, and my specific role here is focused very much on slowing and stopping the progression of chronic kidney disease, as well as transplantation. So this subject area is near and dear to my heart.
That's fantastic. And we're going to talk in a little bit about how much has changed with what we can do for kidney health over just the last few years. But before we get to that, can you talk a little bit about, is kidney health something that people with diabetes should really pay attention to? And how common are kidney issues in people with diabetes?
Sure. Yes. The easy answer to that question is folks with diabetes should be very concerned about kidney health. And the reason I say that is not to make people upset or paranoid, but rather to point out the fact that 20 to 40% of patients with diabetes will end up developing some form of diabetic kidney disease. And this does not mean that they're going to be marching to dialysis. But what it does mean is that they want to sort of sit up and pay attention and do everything they can do to make sure that that day never comes.
Absolutely. Before we dive a little bit deeper into this topic, just to emphasize that a little bit further, what are things that do increase someone's chances of getting diabetic kidney disease?
So the classic risk factors, if you will, for diabetic kidney disease or for precipitating diabetic kidney disease are quite simply poor control of diabetes, poor control of blood pressure, not keeping up with a exercise program, smoking, not paying attention to diet. Those are the sort of basic things that patients should do to prevent the onset of diabetic kidney disease.
Thank you so much for that explanation. Now, when thinking about kidney disease, I think there's a few different terms that maybe you can help clarify. We think about the term chronic kidney disease or CKD. You've heard us say diabetic kidney disease. So if you can share a little bit more about the differences or what those terms mean and how someone might know if they have chronic kidney disease. Would they have symptoms? Is it lab tests? How do they find out?
Absolutely. So lots of questions there to unpack, Sarah, but I'll take them one at a time. So first, this business of acute versus chronic kidney disease. The key difference, chronic kidney disease is defined as persistent kidney abnormalities for greater than 3 months' time. This differentiates it from acute kidney disease or acute kidney injury, which you might see, say, in a hospital setting or even in an outpatient setting coming into the hospital. So chronic kidney disease is chronic, meaning greater than 3 months' time. If you think about diabetic kidney disease, it comes traditionally with significant protein in the urine and gradually progressive decline in kidney function over time. That's the classic description of diabetic kidney disease. However, with proper attention to the things I've already mentioned, as well as certain laboratory metrics or targets, as well as attention and adherence to certain medications that are now available for patients with diabetes, we may be entering an era where not only can we slow the progression of chronic kidney disease, but we should be able to stop the progression of chronic diabetic kidney disease.
The other piece I wanted to know is, how does someone know if they have diabetic kidney disease?
Yes.
Are there symptoms? Do they get lab tests done?
Yes,
How do they figure that out?
It's a great question. There are no symptoms of diabetic kidney disease or kidney disease in general until the disease has progressed to such a great extent that you're sort of knocking on the door, if you will, of dialysis. So upstream, at the time where you can really make a major impact on the direction that that kidney disease is going to take, there are no symptoms. That's the classic problem with treating kidney disease in general and diabetic kidney disease in particular. I should also mention here that it's important to treat the diabetic kidney disease or at least go after slowing the progression of diabetic kidney disease, because there is an intersection between cardiovascular disease and diabetic kidney disease and diabetes in general, that if you treat the risk factors for progression of chronic kidney disease, CKD, you will also be addressing the risk factors for cardiovascular morbidity and mortality. So it's sort of a win-win-win situation for folks who can stay on their game.
So it's critically important to detect kidney disease. The earlier you detect it, the greater is the opportunity to slow and even, as you said, perhaps stop the progression and address the cardiovascular risk that goes along with progressive kidney disease. Now, one of the things that I have heard patients ask is, I look at my labs and everyone sees their labs now in their home portal if they look, and it looks like my kidneys are fine. My creatinine, which I read up and saw as an indicator of kidney disease, looks normal. Is that all they have to worry about, or are there other tests that they should ask for if their clinician that is taking care of them have not done it already?
That is a great question. And the answer is yes. And by that, I'm referring to the presence of protein or albumin in the urine. You may have a normal, quote, serum creatinine, a normal kidney function marker. You may have a normal level of kidney function as defined by blood testing. But yet at the same time, you may have protein or albumin in your urine. And it turns out that that is as good a predictor of the progression of chronic kidney disease, if not a better predictor for the risk for end-stage kidney disease. I would also point out that the presence of protein in the urine is a risk factor for cardiovascular morbidity and mortality. So even apart from diabetes, the presence of protein or / albumin in the urine is a definite marker.
I think that's so important to share. This is something that we routinely try to check in primary care. It's so important that in the primary care practices where Neil and I work, each separately, we're both held to different quality measures related to this. So hopefully your medical teams are checking this for you as a patient or someone living with diabetes to monitor this and make sure nothing has changed progressively over time, because it is something that if it wasn't there one time, we want to check it again in a year. Can keep an eye on that. Absolutely. But if someone does find out that they do have kidney disease, whether from this test, the creatinine, what does that mean for them?
Well, what it means, as I mentioned earlier, is they should sit up and take notice and participate fully with the recommendations of their physician to do everything that they can do to slow the progression of chronic kidney disease, which, as I also mentioned, has an intersection with cardiovascular disease. So it's a win-win. And you may ask, okay, great, but what is the doctor going to help me with? And there's a handful of, say, 6 things that every patient with diabetic kidney disease should pay attention to, apart from diet, exercise, weight management, and smoking cessation. There are 6 things that every patient with diabetic kidney disease should think about. These are the 6 things that are generally accepted approaches to slowing the progression of diabetic kidney disease. Number 1, as mentioned earlier, blood glucose control, targeting the hemoglobin A1C. Number 2, blood pressure control. Blood pressure has been known for decades to speed the progression of chronic kidney disease, and therefore that's a very important target for physicians to go after. Number 3, a medication class called ACE inhibitors, angiotensin converting enzyme inhibitors, and their partners, ARBs, or angiotensin receptor blockers. Number 4, SGLT2 inhibitors. This is a new class of medications, been around just for the past 5 or so years, and has been profoundly instrumental in changing completely the landscape of diabetic kidney disease. And oh, by the way, even non-diabetic kidney disease. This medication is transformative for what folks can expect in the future with chronic kidney disease. It's revolutionary. 5th, statin drugs, the lovastatins, the simvastatins, etc. These medications obviously are lipid-lowering or cholesterol-lowering drugs, but in this population, folks with diabetic kidney disease also have a higher risk for cardiovascular disease. That's the importance of the so-called statin drugs. And then finally, finerenone. It has been shown over the past several years in 2 large trials of diabetic kidney disease that the medication finerenone has been shown to slow the progression of diabetic kidney disease.
Michael, I love that organized approach where we can think in our minds of that list and then bring that list in for our listeners to your clinician who is caring for you and almost kind of go through it like a checklist and say, are we addressing these things? One of the things, Michael, that we really care about, Sarah and I, on this podcast is empowering patients with knowledge. This is a really important area. Is your sense, because the SGLT2s and finerenone are pretty new medicines to all physicians. They haven't been around for more than 10 years at the most, and we've only known about their kidney effects for much less than that. Are they used as often, in your opinion, as they should be?
Thank you for setting that question up, Neil. The answer is a solid no. Now, to be fair, you can expect with any new medication that there's going to be a little bit of stop-start, stuttering approach. Yes, we accept that. But what has further complicated this particular medication is the issue of cost. However, what is great to hear is that this is a huge topic for so-called big pharma, as well as the US government. And you may remember hearing about the 10 drugs that Medicare is going to be allowed to negotiate price on. 2 of those 10 drugs are SGLT2 inhibitors. Why is that the case? That is the case because they are of critical importance for folks with diabetes and folks with chronic kidney disease in general, because, as I said earlier, they are revolutionary in terms of what they bring to the table to slow the progression of chronic kidney disease.
It was pretty amazing. And we all love twofers, right? Yeah. And with both of them, the SGLT2s and finerenone, they're like twofers. You've mentioned a number of times the importance of cardiovascular disease, but I just wanted to make sure our listeners understand that link, that these medicines hit both those things, in addition to blood pressure control and sugar control and the statins that I hope our listeners understand address cardiovascular disease. These 2 medicines, in addition to slowing progression of kidney disease, remarkably help with those cardiovascular endpoints. Is that right?
That is exactly right. And what I'm fond of saying is that we have entered an era, a new era of the control of progression of chronic kidney disease. And if you think about it as the Olympics, the gold medal goes to the SGLT2 inhibitors, the silver medal goes to the finerinones, and then to a class we didn't talk about, the bronze medal goes to the GLP-1A drugs, which are GLP-1 receptor agonists, which are another class of diabetic medications, which are looking like they're going to be slowing the progression of chronic kidney disease as well, apart from their benefits for the control of diabetes.
Now, you're speaking my language with all these medications here, being a pharmacist, these acronyms, the different names. So, looking at them, what are some examples of common drugs in these classes, and how does someone know if they're a good candidate for them?
So I think to think about first the SGLT2 inhibitors, the way to think about it is think that everyone is a good candidate with kidney disease and diabetes for an SGLT2 inhibitor. There's almost no question of that. Go in with that mindset. And the two that that leap to mind that have the most, I should say, the most leeway, if you will, with regard to what level of kidney function you can begin to take them, those would be dapagliflozin and empagliflozin. And those are the two medications that in the trials with progressive chronic kidney disease have been shown to have a profound impact on slowing the progression. It's not to say that the others have not, but you can start those two at a lower level of kidney function than some of the others. With regard to the GLP-1 RAs class of medications, need I only say semaglutide, which is used in also to control obesity. Many of the folks out there may have heard this medication discussed for control of obesity, but suffice it to say that in many ways, as important as the control of obesity, it may play a pivotal role in slowing the progression of chronic kidney disease.
Yes. And thinking of those drug classes, you also mentioned ACE inhibitors, which might be a foreign term to some individuals listening, but for common examples like lisinopril, might be
Exactly.
something that people have heard of before. So hopefully these are things that are starting to sound familiar for people living with diabetes,
Yep.
and something that definitely are important to bring up with your provider if they are not things that you've heard of, to see, am I a good candidate? Is this something that we should be thinking about adding into my regimen? And if not, let's understand why, to figure out if there's a different time and place
Yep.
to
And
potentially
Sarah, you
consider
remind
it.
me of one thing I should make sure I emphasize.
Sure.
ACE inhibitors and ARBs I mentioned are sort of cousins, but do not be on both of those. So you could either be on an ACE inhibitor, such as lisinopril or enalapril, or you could be on an ARB, angiotensin receptor blocker, such as losartan or irbesartan, but not both classes, one or the other, because they're related.
That's so important. And I'm sure this will provoke a question in our listeners, because some of whom are on, say, an SGLT2 and finerenone. Are those okay to be on together?
Yes, they are. Yes, they are. And there is early evidence that the combination of an ACE inhibitor and an SGLT2 inhibitor may in fact enable us to continue on more patients the ACE inhibitor, simply because one of the hurdles that we wrestled with in the past was maintaining a normal serum potassium in folks on an ACE inhibitor. The addition of an SGLT2 inhibitor may blunt that propensity, or proclivity, I should say, for a high potassium level.
Michael, it's really fascinating. In listening to you, it confirms something that I've actually often said to patients that puzzle them at first, which is, I have good news for you. We have detected that you have chronic kidney disease. And what I mean by that, what I then explain to patients, is that the reason it's good news is that we have been checking their serum creatinine as well as their urine for protein every year. So when we detect it early. And unlike a decade ago, and I explained the reason why it's good news is we can do something about it. If we didn't know it was there, it'd be happening anyway, but we wouldn't be able to intervene.
Absolutely. And that is one of the hardest and saddest parts of a kidney doctor's job, is to see a patient that just didn't have that care, didn't have the advantage of an early detection, and that just shows up on the doorstep with things gone bad already.
Now, before we start to wrap up, we've talked about a lot of different medications and things you can work on with your care team to help reduce the risk of progressing to kidney disease or slowing the progression of kidney disease. But what can people living with diabetes do on their own? Are certain things better in their lifestyle, their activities that can help reduce their risk through their day-to-day life as well?
Absolutely. And we did touch a little bit on some of these that are outside the realm, so to speak, of the doctor's office. Things like diet, exercise, smoking cessation, weight management, avoiding medicines that are going to be bad for your kidney function. For example, the classic is the so-called non-steroidal group, the ibuprofens and the like. It's not to say that you can never have one of those medications, but these are the medicines that could potentially adversely affect your kidney function. So again, it's those smart choices that we make in our day-to-day lives that will go a long way toward helping prevent progression.
Now, what if someone wants to learn a little bit more in the details of things that they can do on their own or how to take care of their kidneys? What resources would you recommend?
So lots of options. One of my favorite, and yeah, fine, call it out, but DaVita offers Kidney Smart, so-called Kidney Smart, which is an educational resource that is free. It's kidney health education, and folks who embark upon that journey learn everything from how the kidney works to what they can do to slow progression onward through the entire sort of journey of kidney health and kidney disease, as well as transplant. In addition, obviously, you can talk to your physician because they will have a lot to say and offer in terms of education about slowing the progression of kidney disease. The National Kidney Foundation, and as well, even the patient education option from UpToDate, which is another sort of online educational resource. So to summarize, it'd be your own physician, Kidney Smart as an option that DaVita offers at no cost, National Kidney Foundation, and then UpToDate might be some thoughts that people could pursue.
Fantastic. Those are important resources. And Michael, you've been an important resource for all of our listeners. We're about out of time. Any final thoughts for our listeners?
Yes, I would say let's celebrate the fact that we are entering a new era, and we really are. I am excited and optimistic about how we are going to do in the future with slowing and stopping the progression of chronic kidney disease. We are not where we were even 10 years ago. This is a new age for folks with chronic kidney disease and a new age for folks with chronic diabetic kidney disease. So I'm excited and optimistic.
Your excitement and optimism is contagious. I think our listeners also feel that and feel empowered to ask their clinicians about whether or not they have chronic kidney disease, and then are armed with those list of things that you talked about to do about it. Sarah, any final thoughts you have?
I have to say, I'm also feeling optimistic after our conversation today. The other thing that I found really exciting, to go back to one of the references that Michael mentioned, is the DaVita website and the information in the Kidney Smart class. What an opportunity to go to a free class to learn a lot more about how you can take the best care of your kidneys. I think we've talked before on a prior episode saying kidneys are our friends, and
Yes.
thinking of those friends, we want to take care of them. So I think getting some of the support and resources needed to do that as best as possible in order to be that advocate for yourself is so essential. So looking at the website, there's even a place you can type in your zip code to find a class near you. So check it out.
Absolutely.
Sarah, thanks so much. Michael, thank you so much for joining us.
Thank you for having me. This was awesome.
And I want to thank our sponsor, DaVita. Also, of course, as always, thank you to our audience. You're the most important part of it, and this is why we have these podcasts. Tune in next month when we'll be discussing advocacy for diabetes. For the American Diabetes Association, I'm Dr. Neil Skolnik. Thanks for listening.